Okay, I will present two methods on statistics, and one of them is statistical hierarchy of endpoints, and then I will talk a bit about interim analysis, which is good also for your projects, not only for clinical trials. So this is my background. I'm from pharmacy, and then the COVID came, changed my mind, and I went to medical statistics. I worked for 10 years in a community pharmacy. Now I work more with numbers and statistics, but my love in research, it's bad things happening with medicines. So I like a lot of drug safety, the adverse drug reactions, and pharmacoepidemiology. This is my disclosure. I'm not a mathematician, which is something that I want to say. My relationship with p-value, it's only professional, so I don't like p-value too much. I prefer other things. And I never participated in a non-pharmacological trial, so I don't know why I'm here, but I will try to show you something in pharmacological trials. And like all useful theories and approaches, these two are contestable. And I prepared this presentation before the lovely talks today, so maybe I don't have too much to say. So I would like to start with definitions. What is a clinical outcome and what is an endpoint? And sometimes in my bed and I'm thinking about that, because sometimes it's very hard to define what is a clinical outcome, what is an endpoint, and what is a primary endpoint, secondary endpoint, surrogate, hard, soft. We will see that. So a clinical outcome, it's more or less a measured variable, like death. Okay, it's a good one to see what the outcome is, and endpoint, it's how we evaluate that. So it's more or less scales. And for sure we can try that thing with colors. If we have in a trial the proportion of subjects that have a minimum 1 grade improvement in the score it's used for cardiovascular risk, after using a specific medicine, what we have? An outcome, an endpoint, an efficacy variable, or all of the above. What do you think? Outcome, blue, endpoint, efficacy variable, or all of the above? What do you think?
Raise the card.
Yellow, okay. Okay, yellow, greens, and yellow. Okay, most of you are correct. So all of the above. We have an outcome, which is the proportion of subjects. We have an endpoint, which is the score improvement. And we have an efficacy variable because we are comparing a medicine. So in medicines, we want to confirm or reject hypotheses, like in all the statistics. And we prefer a single primary endpoint that should be selected. Never happened. Not in pharma, we don't have any one primary endpoint. We don't have that, because in the end, pharma are spending money, and when they spend money, they want to test as much as they can. So an endpoint, it's that one. It's defined as an overall outcome that a clinical trial aims to measure, and it could be a disease, characteristic, a health state, a symptom, a sign, or even a test result. And there are a lot of different endpoints. One are primary, which is the main objective of the trial. For example, try to understand the disease-related death. And the success of the clinical trial, it's very dependent of the primary endpoint. So it is what we want to test. Then we have the secondary outpoints. Okay, we have that or non-that, but sometimes we want the improvement of the disease. So this is a secondary endpoint. And in real life, this is what we happen. In a clinical trial, this is related with acne, and we have a lot of primary outcomes like the absolute change in lesion counts, like inflammatory or non-inflammatory, the proportion of subjects we have improvement in some scales, or even the proportion of subjects that have a specific score in the scale. And in the secondary outcomes, we have a lot of tests, because in the primary outcome, we only test in the end of the trial, like 12 weeks in that example, but in the secondary outcomes, we test in the 2 weeks, 4 weeks, 8 weeks, and sometimes more, and these are only the outcomes and the endpoints tested for efficacy. Then we also have the safety endpoints. And the safety endpoints are very hard to assess and are very hard to think about it in the beginning of the trial, because we never know what will happen in the safety of a medicine, for example. So it's to determine if the intervention is safe, but we don't necessarily have to have that problems identified prior to the trial, because sometimes the worst problems happens in medicines, for example, in interventions. So safety, it's very hard to assess, and a lot of unexpected safety events occur during a trial. Then we also have other classifications for endpoints, like hard endpoints, death, okay, it's 1 or 0, we die or we don't die, but we have also soft endpoints, like the level of pain. You can have low pain, high pain, and feeling better, it's also very difficult to assess, so we can have lower or higher values. And in the end, we also have surrogate endpoints, which means we are testing or measuring something that could give us another conclusions. Like, for example, if we assess the cholesterol level, this is a surrogate endpoint for the risk of having cardiovascular disease. If we have a higher cholesterol level, we have more risk about cardiovascular diseases. So in trials and in medical trials, in drug trials, we have a lot of multiple test problems, and it's very common. A lot of trials have a lot of endpoints, primary ones, secondary ones, a lot of them, because most of the times we have several other treatments, we have more than one endpoint, we have more than one population or one group, and we have control repeatedly in time. So these multiple tests require then multiple statistical methods to analyze. And one of the standard use is that one, when we assume our alpha, our type 1 error, it's the p-value, the 0.005. And if we are testing, for example, 2 endpoints, and we assess the error in one endpoint, and then in the other one, we are increasing a lot our error that we can have. So, for example, if we test 2 independent tests, we can have an error proximal to 10. So, and this is only for 2 endpoints. If we go for more endpoints, we can increase the error until almost 1. Not 1, but almost 1. And for example, if we have 10 endpoints, we have about 40% of error probability. So it's a lot. And on that, we have some methods in statistics to correct that. One of the well-known, it's the Bonferroni correction, which we divide the p-value for the number of endpoints we are testing. It's not very used in statistics anymore, but it's the base for a lot of other tests. But it's very conservative, because if you have 10 endpoints and you have an alpha of 0.05, and we divide by 10, we have 0.005. So it's very conservative, and a lot of times this results in non-statistical results. So one of the methods is that one, the statistical hierarchy of endpoints, and I don't know if you already heard about it. Do you have any idea what we do in that case? We prioritize primary endpoints over secondary in analysis, we treat all the endpoints equally, we only focus on secondary endpoints, or we combine all endpoints in the single analysis. Do you know? Okay, blue ones. Okay.
We will not apply the p-value to see.
Okay, blue ones, you are correct. In fact, we prioritize the primary endpoints over the secondary in the analysis. But this is the hardest part because it requires a lot of medical, in case of medicines, medical knowledge to understand what is the main endpoint and what it's not. So this is the definition of two methods. One is distributing the risk overall by all the endpoints, dividing the p-value by the number of endpoints, and the other one is the hierarchy test procedure, which have the additional advantage of identify which are the main endpoints. And this is not a very good image, but this is an example of clinical trial called Respire. And in that clinical trial, the first efficacy, it's the time to have an exacerbation in asthma. And only if that is significant, we can go to the secondary analysis, which is the frequency of exacerbations. And only if that is significant, we can go further on our endpoints. So what happens? We test the first one. If it's significant, we go to the second one. And if it's significant, we move on and on until we have a hypothesis that it's rejected. And when we have the hypothesis that it's rejected, we stop the analysis. And for sure, it has some advantages, like it's a very simple procedure. We test less than in other methods, so it requires less time also. And it's optimal when hypotheses early in the sequence are associated with large effects and perform poorly otherwise. If we think about the example that I gave to you, in a test that we have 12 weeks, we can test 12 weeks, then 10 weeks, then 8 weeks, and we can see when the treatment starts to be effective. And it also has some disadvantage, like once the hypothesis is not rejected, no further testing is allowed. So maybe we lost some conclusions here, but in the end, the conclusions that we are losing are not so important for us because when we order the endpoints, we put them in the end. And this is another graph that represents that. In the first test, if it's significant, we go to the second hypothesis, but if not significant, we stop the analysis. So we consume a lot of less time. And then we have also in that methodology, we can accumulate type 1 error. So in that analysis, we can also have that type of analysis called fallback procedure when we also have the sequential analysis, but it's also divided by the number of analyses we intend to perform. So it's also more conservative. It's not very used yet. The other one it's more used, but it's more conservative, so the conclusions could be stronger because the p-values will be lower as well. And then these are the advantages: the control of type 1 error, also the efficient use of resources, because if we stop the analysis, we don't need to compute more analysis. For you to have an idea, in pharma industry, all the analysis in Europe and US need to be performed in SAS, and SAS it's very computing thing, so a lot of analysis require a lot of time, so we can save a lot of resources on that. Then in the interpretability of the results, it provides a logical sequence for evaluating the treatment, and it enhances also the decision making. And this is a question that you could have now, how to order the endpoints in the hierarchy. It needs to be carefully selected to correspond to relevant clinical endpoints. and be sufficiently common to enable the study to be conclusive in some endpoints. And this is an example for chronic obstructive pulmonary disease, when the first endpoint is the lung function with the FEV. The FEV, it's the volume of expired in lung. Then the number of exacerbations, then the dyspnea, and then specific diseases, health-related quality of life, and then they go on and on. And you see that the importance of the endpoint is reducing in the example. And these are the key messages for that part. Hierarchy analysis prioritizes and controls the sequence of testing. It allows a systematic evaluation of endpoints based on the clinical relevance or logical sequence, and helps maintain statistical rigor, control the type 1 error, and provide a structured approach to interpret multiple endpoints. Now I will talk a bit about interim analysis. What is interim analysis? In common sense, it's an analysis, a statistical analysis that we perform somewhere in the trial, in the middle, in the beginning, in the almost the end. Somewhere we will perform an analysis to understand if something is going right or wrong. And the primary purpose of that analysis, that statistical analysis, are the early assessment. For example, the participant recruitment. If we are in a multi-centric trial and one center is recruiting a lot and another center is not recruiting so well, we can assess that in the interim analysis and try to have compensate measures to understand what is happening. Sometimes not recruiting too much, it's bad, and sometimes recruiting too much, it's also bad, because we can also have a bias inside the center. Then try to understand if we have adherence to the study protocol or not, and why. The study protocol is well designed, it's not well designed, what happened, and the quality of data. If we are asking too much and the quality of data is very low, maybe we need to change the way we are asking. And then some potential safety concerns. For example, in drugs, if we are testing 2 drugs and there are a safety problem, we can assess that here. Then another advantage is the timely decision making, for example, for safety as well. The sample size adjustment. We can have more, we need more patients to prove something, or we need less patients because we already have a lot of data. And the treatment effect estimation, the safety monitoring, also some ethical considerations. I will show you an example on the ethical considerations after, and also the early trial termination, for example, with a safety problem. And there are also some potential disadvantages. For example, the increased risk of bias. If we look at only a small number of patients, for sure we can have some types of bias. So get strong conclusions in the early interim analysis could be very, very hard to do. Then it could also increase the type 1 error, because we are constantly testing and testing, so the error could increase. It also compromises the statistical power. For example, if we reduce the sample size to save resources, it could be compromise our statistical power. It increases the administrative burden. We need a statistician for the analysis, for sure, for days, for weeks, sometimes, to do the analysis. So more administrative burden, more burden, also financial. Then this is an incomplete follow-up. We can need to potential unblinding the trial as well, and it's an ethical challenge as well as disadvantage, because if the trial is terminated earlier, it may limit the ability to have comprehensive evidence on the treatment safety and efficacy. So this is an example to hand. Let's consider a clinical trial testing the effectiveness of a new drug in a very specific type of cancer. And the trial aims to enroll 500 participants to assess the drug efficacy in reducing the tumor size and improving the overall survival. In the middle of the trial, we do the interim analysis like we gonna do in the end. And for the first 250 participants, we could have three scenarios. The good one, the positive interim analysis, the negative one, or the inconclusive one. And for that, we have some potential conclusions that we could have. In the potential positive interim analysis, for example, we can early identify the treatment benefit. And this is cancer. Sometimes we don't have too many drugs for cancer. So if we have a positive benefit, we can unblind the trial and then have that ethical consideration. So we have two arms. One is doing the drug that are in test, and the other one is doing placebo, for example, or other drug. If we see treatment benefit, ethically, should we not stop the arm that are not doing the best treatment and put that patients inside the other treatment arm? Yes or no? This is a question for you to think. But based on the positive interim analysis, the Data Safety Monitoring Board may recommend the early termination of the arm that are not doing the best drug and ensure that that control group starts to do the other drug. Then we can also have negative interim analysis, and this is very common for drugs, for very, very specific adverse drug reactions for drugs. So when we have a problem in safety during the trial, we can also stop the trial and have resource optimization, because in the end, if we have a negative, strong conclusion here, the researchers could stop the trial and save resources until the end of the trial. And then for improve the participant safety as well, if safety concerns arise during the interim analysis, such as unexpected adverse events or adverse drug reactions, the data can be assessed to determine if immediate action is required or not. So the trial sometimes stops here due to negative interim analysis. And then we can also have inconclusive interim analysis. And in the inconclusive interim analysis, we also take measures like improve, for example, the size of our sample to get more power in our conclusions, for example. And also we can decide to make study modifications. And during the day, I understand that the adaptive clinical trials are very difficult to do. But this is what interim analysis help. Sometimes we are doing the trial and we start to have conclusions here, but we need to review our protocol and restart the trial. It's not restart, but continue in other ways. So this is the result of a lot of interim analysis. Changes in the protocol, changes in the trial, and then we continue other way. And this is one of my key message. This girl, he gets a positive result. This is the interim analysis. Sometimes we get positive result, but the sample size is only one. So we need to check more and don't stop the trial or say that the drug is very effective, so stop some arms and get patients in other arms, because sometimes we are looking for samples that are not, we cannot have any conclusions. And interim analysis in clinical trials allow for timely decision making. It provides an opportunity to assess the trial progress, the treatment efficacy, and also the safety, which is very positive. First, do not harm, so we need to have attention to our patients, and also helps to optimize resources, adjust sample sizes, and make data-driven decisions. And that's it. Thank you.